Hi, everyone. Hi everyone. Good morning, good afternoon, good evening, depending on where you are, joining from. If you can hear my voice, and I want to say welcome and thank you for being with us today. Um, my name is Tafari Taklu. I'm a lead for quality of care and training at PSI Ethiopia, based in Addis Ababa. So I will be your moderator for this webinar. Thank you so much again for joining us today. So this webinar is on contraceptive continuation and discontinuation and tracking and measuring and defining success for adolescents and youth sexual reproductive health program in sub-Saharan Africa. With that, and today we have panelists here, as you can see from the slide. And we have Dr. Abdinago Musau from AS360 PSI, is the Senior Research and Learning Lead. And then we have Al Hassan Al Haji Bulama from SFH Nigeria. And then we have Dr. Hilda Sendi from Tiko, and she's a global research and analytic director at Tiko. And then we have Wanjiku Kingori from PS Kenya, program coordinator, and then again Gabriel Appleford from FP 2030, the consultant at Avenir Health and working for Track 20 project at the FP 2030. So with that, and we have, this webinar is organized in collaboration with PSI, Population Service International, Adolescent 360, SFH, TICO, FP 2030, and the rest of the team as well, as you can see. So with that, I'm going to introduce some of the reminder for you. So this webinar is being recorded, and we will be sharing the link at the end of the webinar. And at the same time, I want to reassure that you can submit your questions in the chat box at any time, so that we will address your question during the Q&A session. This is the second webinar, follow up and the continuation from the previous webinar that we have a month ago and last month. So that focused on approach and strategies to support adolescents and use contraceptive continuation in sub-Saharan Africa. So I think if everyone and the rest of the participant is ready and are we can proceed, but that is possible as well, to wait for quite a few moments to every one of the participants joining and ready for the webinar. So is that okay? If you can hear my
Hi,
voice.
hi, Safari. Yeah, I agree. I think we can give about 3 minutes for people to join, and then I will continue.
All right.
Thank you.
Okay. Okay. Thank you. Okay. Thank you again, once again. So, to use our best time of our time, so that we can proceed with the existing participants, so that today's webinar is as I try to mention is the contraceptive continuation, discontinuation tracking and measuring defining success for adolescent use health, sexual reproductive health program in sub-Saharan Africa. And this webinar is organized with the PSI, Adolescent 360, Tiko, and FP 2030. So these are, our panelists from PSI, Dr. Abdinago Musau, Al Haji Bulama from Society for Family Health, SFH Nigeria, Dr. Hilda Sendi from Tiko, Wanjiku Kingori from PS Kenya, and Gabriel Appleford from FP 2030. Next slide, please. So this webinar is a continuation of the previous from the previous, webinar that is, happened a month ago, and was on the approach and strategy to support adolescent and youth contraceptive continuation in sub-Saharan Africa. So during that webinar, we already outlined, the importance of, contraceptive continuation, the strategies and approach and areas of, contraceptive continuation in sub-Saharan Africa, also discussed during the time. So this is, the follow-up from the previous webinar. So this is today we'll have, again, the series of the second webinar on contraceptive continuation discontinuation, especially tracking and measuring and defining success in areas of contraceptive continuation for adolescent youth sexual reproductive programs in the region of sub-Saharan Africa. Next slide, please. So today we have a couple of points to discuss, and the first one is we'll have we'll have the use discontinuation of contraceptive methods, and in the meantime I want to again remind the participants to introduce themselves, from where they are, their organization, their name, their position, and where they are joining. And I really appreciate if you can do that in the chat box. At the same time, this webinar is being recorded, and you can submit your questions in the chat box at any time during the presentation. So we have a couple of webinar outlines. The first one is the use discontinuation of contraceptive methods. This is Gabriel Apfo from FP 2030 will walk us through this the use discontinuation of contraceptive method, and then we'll have Dr. Hilda Sendi will go and present the contraceptive continuation by adolescents, and especially from Tiko's approach of measurement of the contraceptive continuation. And then we'll have our colleagues from PSI 366, and we're going through the presentation and share the approach for tracking and measuring contraceptive continuation. And then we'll have Wanji Kingori will facilitate the interactive session. And at the end of the presentation, we have the Q&A session, so that the questions and any reflection will be entertained, and we'll try to address the questions that they do during the presentation as much as possible. Next slide, please. With that, I will hand over and to Gabriel Apple from Apple4 from FP 2030 to go through the use discontinuation of contraceptive method. Gabriel, over to you.
Thank you very much. I can't put my camera on, so I will just proceed through the presentation. So I'm presenting on behalf of Track 20, which is the monitoring and evaluation project that supports FP 2030. And I'm not alone. I've got colleagues, Priya and Kristen, that supported the data and analysis that you'll see in this presentation. Next slide. So we did, as I said, some analysis of demographic and health surveys, particularly looking at calendar data and looking at countries with surveys that had been done post-2020. So we identified 8 countries in sub-Saharan Africa, and they're listed here, and they form the focus of our analysis for this presentation. In terms of what we looked at within the DHS, we looked at the monthly contraceptive use and pregnancy information, reasons for discontinuation, and also looked at discontinuation at specific points in time, so 6, 12, 24, and 36 months after starting a method. And women were categorized in age groups based on age at first month of use. Next slide. So I think to start the analysis, a conclusion that we made was that total discontinuation for 15 to 19-year-olds is similar to older women in most countries. So our countries of interest are lined up here. And you can see that the 15 to 19-year-olds are in the bolded pink color. So you can map that across in terms of other age cohorts. But total discontinuation masks the variation in discontinuation amongst different methods. And if 15 to 19-year-olds are using higher discontinuation methods than older women, for example, EC or condoms, we would expect them to have a higher discontinuation overall. So to frame the discussion or our analysis today, we looked at method mix and method-specific discontinuation. So you can proceed to the next slide. So here we're looking at method mix, which is different for 15 to 19-year-olds compared to older women. So for each country, we've got two columns. On the left, the 15 to 19-year-olds, and on the right, the 20 to 49-year-olds, so lumping everyone together. One thing, we looked at a range of methods, and those are indicated and color-coded, as you can see. I just wanted to highlight that for our 8 countries of interest for this presentation, the method mix is not high for adolescents, for IUDs and pills, compared to 20 to 49-year-olds. And in fact, only 3 countries, Burkina Faso, Kenya, and Senegal, do we have enough data to calculate age disaggregated IUD discontinuation. So in general, it's quite low. So what we can see is that condoms are a larger proportion of the method mix for 15 to 19-year-olds in 7 of our 8 countries. And it's interesting that the only exception to that is Madagascar. As you can see, the very small sliver of blue there. And looking at traditional methods, we also see that adolescents are relying on these vis-a-vis their older age cohorts. So again, in 6 out of 8 countries that we looked at, the exception being Côte d'Ivoire, which has a slightly smaller proportion, and Mozambique, which again has a slightly smaller proportion. Finally, implants are a larger proportion of the method mix in only 3 countries, and those are Mozambique, Senegal, and Tanzania. So in general, the patterns are quite similar. We do have some exceptions, and the method mix is a bit diverse. And we'll dive into that on the coming slides, looking at the 3 most popular methods. Next. So here we're looking at implants because it is one of the popular methods used by 15 to 19-year-olds. And again, looking at the bolded pink line for our adolescents across the 8 countries. So you can see that discontinuation rates are high. However, they're often near the rate of 20 to 24-year-old discontinuation. So looking at that broader youth cohort. We'll look at the next slide with injectables. And in this context, looking at injectable discontinuation by age at start of episode, we see that in almost all countries, adolescents have the highest discontinuation of injectables, quite significantly higher in some contexts than it is for other age cohorts. Next slide. And then finally, looking at condoms, this is a bit of a reverse story where condom discontinuation is low amongst adolescents compared to other ages. And you can see that again in the bolded pink line. Next slide. So we also delved into the common reasons for discontinuation. And I think a little bit to my surprise, in most cases, most teens discontinue due to the desire to become pregnant, rather than from a contraceptive failure resulting in pregnancy. However, this does vary across countries, as we can see, and also across methods. So just to highlight a few examples in this slide, the desire to become pregnant is more prevalent in Senegal for implants than it is for Kenya, where it is quite low. In contrast, for injectables, the desire to become pregnant in Senegal is significantly higher than Ghana. So all our other countries sort of fit in the middle of these extremes. And then finally, with male condoms, not much of a variation do we see here, but it's quite, it's a reason given for Côte d'Ivoire and Burkina Faso on the other hand, so all the other countries in the middle. Health side effects also vary across countries and across methods. So just picking out a few examples here, side effects are quite high, and the reason for discontinuation in Ghana at 14% compared to Mozambique for implants. And then when we look at injectables, Côte d'Ivoire has a very high reason for discontinuation at 26%, and at a lower end of the spectrum is Burkina Faso at 4%. Male condoms, the range doesn't vary as much, but it is a reason given in Kenya, for example, compared to Mozambique, which is at 0%. We also looked at the failure of methods and reasons for discontinuation. You can see it's slightly higher in Senegal at 5% for implants, vis-a-vis our low end of the spectrum for Ghana and Mozambique. And injectables, not so high, but compared to Ghana and Côte d'Ivoire at 6%. Kenya also accounts for some discontinuation there. And again, a similar story with condoms, where you see that in Ghana, it's a reason given, and in Madagascar and Tanzania, it's not mentioned. So overall, more adolescents discontinue, and just honing in on this message, due to desire to become pregnant rather than from a contraceptive failure resulting in pregnancy. Next slide. So again, we delved into the reasons for discontinuation across age groups and looking at our countries of interest here. So we wanted to give you a sort of a final summary around this. A large proportion of women, especially at younger ages, discontinued to become pregnant. We also saw that that varied across countries. Side effects remain a significant reason for discontinuation. Therefore, the quality of our programming is important, and providing options to young women is equally important. In most countries and across age groups, method failure, which is in the lime green, so relatively small, is not a major reason for discontinuation. However, we do see a large proportion of women who do not give an answer or say other reasons. So that's in our pink there. And we can't really explore that. We don't have information on that. But it is something that's coming out in the surveys. Next slide. So to go back to the point of my presentation, is discontinuation tracking a primary interest for our programs in sub-Saharan Africa? These were our takeaways from the analysis, but these are open to discussion and debate. But we saw in many contexts, adolescent discontinuation is not high relative to other age cohorts. So it's more or less running in the same direction as other age cohorts, and in some cases is the middle of the pack. The reasons for discontinuation vary across countries, but do include a desire to become pregnant. What we also see and suggest is that for all age cohorts, focus should be on quality provision of contraception and other SRH services. Recording discontinuation, because we are the monitoring arm of FP 2030, we can't have a presentation without talking about routine health information systems. But it's Track 20's opinion that recording discontinuation within the routine HIS is not necessary unless there's a large difference in discontinuation rates across age cohorts. And just a reminder that a lot of adolescents are accessing contraception over the counter and via pharmacies, which typically would not be tracked in any case in routine HIS. So essentially, adolescents are very much accessing methods as and when needed, more on a transactional basis, which we explore a little bit more in the next slide. So to prepare for this presentation, we also went back to the literature. The references can be provided as part of this presentation package, but just things that we can remind ourselves and that we know from the literature. Unmet need for FP is an issue for our adolescents, as is access to and use of a broad spectrum of ROMCA services. So areas for tracking include unintended pregnancies, as these pose an increased risk of maternal and neonatal mortality due to unsafe abortions, lower ANC utilization, insufficient birth spacing, and high-risk pregnancies. So in our opinion, these are key areas for tracking for adolescent programming. Also, areas for programming, and I know that you touched on this in the previous webinar. Unfortunately, I wasn't there, but definitely integrated health promotion strategies and working across both the public and private sectors to allow young women a choice to select the level, quality, and cost of their services. Also, as part of our programming, looking at combining strategies. So our analysis suggests that there could be improvements made, and the literature supports this, around clients' knowledge about SRH services and commodities, including what is on offer, how to use commodities, and true side effects of commodities. So really understanding, disaggregating from myths and realities. So that combined approach for our programming. Also, the opportunities we have to mobilize, looking at engaging healthcare workers, particularly those in faith-based facilities who may be a bit conflicted about what to provide to young people, to improve their knowledge and attitudes and facilitate access to services for adolescents. This type of strategy could be combined with civil actions that are taken by civil society and communities, so not to neglect our activist role in promoting access for adolescents. Also looking at tapping our opportunities, the role of the private sector, especially pharmacies for adolescents. While its role is less clear in the literature, interactions are a missed opportunity to discuss SRH more broadly and bridge interested young people to a more regular form of contraception, because we know they're going in there for EC or condoms. And then finally, thinking about these forms of interaction and understanding if they're youth-friendly enough. Some of the studies suggest that they are, but they don't provide much accuracy or much scope in terms of those interactions. But this, looking at how we program with this kind of current pattern of use, we don't want to fundamentally alter current interactions, because to some extent they are working. Pharmacies are providing, and OTCs are providing adolescents with access to some form of contraception. So it's just to think about our programming in terms of scale and not overthink how we program some of these interactions, so that we're building on what's working and really trying to augment that. And for the next slide, I'll say thank you.
Thank you so much, Gabriel. Really appreciate the wonderful presentation, especially having those data from the 8 sub-Saharan Africa, especially how the method mix and how the discontinuation rate and the like. So I really wonder how the discontinuation for the at the adolescent age is higher for injectable and lesser in for condom. At the same time, the insights that you shared and provided in areas of for tracking, programming, and strategies of this data. And I really thank you so much, Gabriel. And then we'll proceed to the next presenter, and we'll give to Dr. Hilda Sendi to go through the contraceptive tracking and continuation. Over to you, Dr. Hilda.
Thank you, Teferi, and hello, everyone. So I'll be sharing how Tiko is tracking the uptake of contraceptives and the continuation, how we measure continuation. Our focus being adolescent girls and young women, age 15 to 24 years. The age would normally vary by market or by country. In some country, we program for adolescent girls 15 to 19 years. In others, it's 15 to 24 years. So a bit of the focus will be on the 15 to 19 years in this presentation. Next. But just a little bit about Tiko for anyone who may not know much about Tiko. We are an African non-profit organization that leverages the power of a tech-responsive world to deliver sexual and reproductive health and other health services to adolescents and young people, most of who are underserved in urban and peri-urban areas of the countries we work in within the region. We use a tech-powered model to connect users who'd otherwise have been fragmented or stakeholders who'd otherwise have been fragmented, so that we make it easy for adolescents and young people to have access to the much needed sexual and reproductive health services and other services that Tiko supports. And they are able to access these services at no cost. So when we bring these players together and when we support young people to access services at no cost, we are in essence removing the barriers that most young people face, many of which are social and financial in nature. For example, our research shows that a lot of adolescents prefer to access services in private facilities, yet there's usually a cost element to that. So when they access services at no cost, then we are removing that financial barrier. There are many other barriers, of course, in terms of be it community norms or be it quality of service, quality of care that the health providers are giving to these young people. Or support from their partners and so on and so forth. So Tiko works at really helping these young people to address these barriers and thereby empowering them to be change agents of their own sexual and reproductive health and health in general. We work in Kenya, Uganda, Ethiopia, Burkina Faso, Zambia, and South Africa. Next. And so for the interest of what we are discussing today, I think I wanted just to share first and foremost how we collect data on the platform, being a tech-enabled approach that we use, which is really the data that we use to track service uptake and to track continued use of contraceptives. So Tiko uses agents in the community, and these agents are community mobilizers and community health promoters. And so these community agents register young people on the platform. They could register them when they have a phone, if the young person has a phone. And if they don't have a phone, these agents have a smart card that they can register these young people on the Tiko platform with. Sometimes these young people register themselves or register their peers. And then the platform also helps us to validate. It's structured in such a way that it validates every interaction that a young person has on the platform. So if, for example, they've decided to we have a 15-year-old in an urban area in Kampala who has decided, I want to use an oral contraceptive method, they will go to the facility and they've chosen the facility. So if they have a phone, and if they've decided the service they want to take, they will send a code to Tiko's cloud-based system through either an SMS or other messaging service like WhatsApp or Telegram. And then the Tiko platform will respond with a code to the young person, who will then give that code to a health provider. This health provider then puts that phone in the Tiko app that they are using. So the health providers and the community mobilizers and practitioners have Tiko apps that they use within their work through the Tiko platform. Next. So this back and forth process is just to ensure there's validation of the interaction. And so this validation helps Tiko to generate a data point. So in essence, it's able to record information of a service having been given, to who it has been given, what service it is exactly that the individual has received, and the type of facility or the location that this service was accessed. And so we are able to track this across the whole range of services that Tiko supports. This validation is, we refer to it as a digital handshake because it is a confirmation that indeed an interaction has been had, and it enables Tiko to collect an accurate data point on the cloud-based system. And so that data is what then we are able to use to monitor service uptake and continued use of contraception. So when a young person registered on the platform, they were given a code, be it through a phone or the smart card. And so they are supposed to come back with the same code. And so what the back end of the Tiko system does, it continues recording data points on this individual. So we're able to do a longitudinal tracking of all the services that this person is taking. So we can tell, for example, if through a year, they've taken the range of FP methods they've taken, and if they've also added any other service, and because we also support integrated service uptake. This process just ensures the accuracy of the data that we record, but also that objectivity, because the data one is real time. So we are able every day to see, the services being taken, but also because of having, creating a profile of a user and tracking them over time, we are able to longitudinally track them over time and just assess their behavior through the platform. Next. But beside this data that is collected on the back end of the Tiko platform, we do complement our tracking of FP uptake with other data that we either collect on the platform or off the platform. We are, for example, conducting routine client exit interview surveys across all the countries that we work in. And these are done mainly on a quarterly basis. In some countries, we do this on a monthly basis. It really is because dependent on need, program need. We assess, amongst other things, the quality of service they've taken, the quality of service they've accessed, but also their plans to use FP in future. So you'll see how that comes together with the other data. We are also able to use the platform to collect data from Tiko users through our call centers. And we also collect data off the platform with Tiko users using qualitative methods. Next. So how do we then monitor service uptake on the Tiko platform? Some information is cut, but basically what this just shows us is that we are able to tell, real time, but also within a period of analysis, how many short-acting methods have been taken through the Tiko platform and how many long-acting reversible contraceptive methods have been taken through the system. So this is data, for example, for the year ending August 2024. Next. And we are also able to disaggregate this data by market or by country and just look at the patterns of service uptake. So when you look at this chart, again, for the same period, the year ending August 2024, we see in South Africa that the most popular injectable method among adolescent girls and young women 15 to 24 years was an injectable, which is different for Ethiopia, for example, where the most popular method is oral contraceptive pills. And in Kenya, we see oral contraceptive pills and implants being the most popular methods that adolescent girls are using. Next. So how about the continued use of FP services on the platform? Next. Now, given the way the Tiko platform is set up and the type of data we are able to gather at the back end from users when they access FP services, we have a unique way of tracking continued use of contraception on the platform. And so we have a definition that really captures this. And so we define contraceptive continuation as the percentage of adolescent girls or young women based on the market and the age category. So the percentage of adolescent girls and young women who take up a contraceptive method, and within a 12-month period, we keep the analysis mainly to a 12-month period, and who come back for a refill of their method within 2 months of their method expiring. And we cover those who either come back for a refill of the same method they took, or if they've switched to another method. So this calculation captures both those who've retained the method or they've switched to another method. Our calculation focuses on both short-acting and long-acting. For long-acting reversible contraceptives, we look at whether or not at the expiration of the method, whether they've come back for a refill of that method or another, or if they removed an implant or an IUD, if they've taken up another method. So that will determine whether or not they are referred to as continuous or discontinuous. Next. So just an example based on this definition of what we see in Kenya is that when we've done an analysis of contraceptive continuation for both short-acting methods and long-acting reversible contraceptives, and we see amongst girls aged 15 to 19 years, for the period ending August 2024, 37% of those who took up a short-acting method continued, whereas 61% of those who took up a long-acting method continued on a method. And this translates to about half or 50%. Next. Now, because we complement our analysis of use of FP or continuation of contraceptives from the data on the back end of Tiko with other data, we are also able to look at the behavior of our Tiko users and sort of like understanding this and determining what strategies we put in place to encourage continued use of contraception. So this slide gives us data that we collected in Kenya in July of 2024 through client exit interview surveys. And this data shows us that more than 50% or more than half of respondents in these CIs who had come for an FP service were new adopters. So 55% were using an FP method for the first time, whereas 45% were continuous. Now, amongst the 45%, 34% came back to get the same method, 11% had switched to another method. So at least this helps us to just understand, aside from what we see on the Tiko platform, what else are we observing with other data that we collect on the Tiko platform? And of course, this data on this slide is reported as opposed to what we observe on the Tiko platform with the Tiko data at the back end. Next. Now, the platform also allows us to assess, of course, service uptake, service continuation, but critically, switching of FP methods, because it's important we understand, again, in terms of continuing to understand the behavior of our users. So when we look at the data for period ending, again, August 2024, amongst 26,000 users who had switched methods, we observe that most adolescents, and this is data for Kenya, so most adolescents 15 to 19 years who are using an IUD or who are using an implant switch to an IUD and oral contraceptive pills. Most injectable users switch to oral contraceptive pills and implants. And then we see most IUD users switch to oral contraceptive pills, and this is 83% of them. And then most oral contraceptive pills users switch to implants and injectables. So even though the slide may be small, I've indicated in text on the right side, it's just an interpretation of what the chart shows us. Next. Now, again, looking at as well, you know, going beyond the data that we look at at the back end, and looking at what other data sources are telling us about contraceptive continuation. So this chart gives us data from the client exit interview surveys that we collect, merged together with data from Tiko users on the back end of the Tiko platform. So we sort of merge the data from CEIs together with data from the back end. And we did some survival analysis here just to try and predict behavior of Tiko users. So these are users aged 15 to 19 years in Kenya. So we wanted to understand, for all those who have taken up a method and who responded in a CEIs, what is the what is the probability that they'll continue using a method. So we've got quite a bit of analysis, but I'm just sharing a snippet of our analysis amongst those who took up an oral contraceptive method. And we see that the probability of them continuing on a method is about half. So half of the users would continue using an oral contraceptive pill based on that period of analysis that we do. Remember, that is a period where we are adding 2 months when the method expires, giving them 2 extra months to see what their behavior will look like. We see about half of them would come back. Next. So just looking at what we observe through the Tiko platform and with the data that we are collecting from other sources, we wanted to understand, what is it that really influences uptake of contraceptives, but also continued use of contraceptives. And we use, of course, other data sources that we complement the Tiko data with. Next slide. Yeah. So aside from client exit interview surveys, we conduct other data, as I'd indicated. This slide gives us a snippet of insights that we gathered from a qualitative research that we conducted in May of 2023 in Kenya. So I'm presenting a lot more of Kenya because that's where we've had almost a completeness of the data we've just been analyzing. So we wanted to understand, of all Tiko users within Kenya, on the platform, what's their behavior like? And how does their behavior, and including sexual relationship, influence contraceptive uptake and continued use? So with this qualitative research, we were able to come up with 4 main segments of the Tiko user, and this is the adolescent girl. We found out that when it comes to relationship statuses, we have 4 main segments. So there are girls who are in a stable relationship. We have girls in long distance relationships. We have girls who have multiple sexual partners, and we have girls who either have a child or are married. So when we looked at the behavior of girls who had a steady boyfriend, we realized that most of them preferred to use a long-acting method, a longer-acting method like an injectable. But then they would very easily discontinue use of this method if they faced side effects or if the relationship ended. And then we have girls who had multiple sexual partners. And so most of these girls would use more shorter-term methods of contraception, like pills and injectables, but then they will combine these methods with other barrier methods to prevent them from STI infections. So this would include condoms. But then these girls will continue using the method as long as they are not facing side effects. So the moment they face side effects, they discontinue the method. And then we had girls who are in a long distance relationship. And this includes those in boarding school or those who have boyfriends living in other towns. And so from our client exit interview surveys data, we see that 20% of the girls we track through our CEIs are in boarding school. Remember, these are girls 15 to 19 years. And so most of those will use mainly very short-term methods of contraception, like emergency contraception or condoms. And when they're in school, they will not use a method at all. So discontinuation is the highest within this category. They don't use a method because they don't see themselves at a risk of an unintended pregnancy when they're in school. And a lot of them will go to school for like 3 months or 4 months of the term.
Dr. Hilda, thanks so much. So, I will, could you please summarize just, to best use of our time to summarize in just 2 to 3 minutes. So we are having, the time is, running. So yeah, thank you.
Okay. All right. So next slide. So we also look at what are the other factors that are influencing discontinuation. We see age of the user, the education level, and relationship status being really critical. This just backs up the point I'd made in the previous slide. Next. So infrequent sexual activity, switching of a method, and side effects are the main reasons why most girls in Kenya discontinue the method they're on. And in Ethiopia, the main reasons are wanting to be pregnant, side effects, and infrequent sexual activity. Next. So in conclusion, the Tiko data really helps us to do real-time tracking of behavior And we are able to track the objective uptake of contraception and continued use. And then, of course, when we combine with other data sources, we are able to get a 360-degree understanding of our Tiko users and their behavior, and do and make necessary adjustments to our interventions to just improve continued use of contraception. Thank you.
Thank you so much, Dr. Hilda, and this is really an insightful presentation, and you walk us through how we know that Tikos, collecting and tracking contraceptive continuation, and how we're defining the contraceptive continuation, and as well as the contraceptive continuation rate and the reason for continuation with different method mix. I thank you so much. So just a reminder, to all participants, I will invite you to, keep posting your question in the chat box. And I now invite Dr. Musao and Bulama to walk through us, the AYSRH approach for tracking, measuring contraceptive continuation. Dr. Musao, over to you.
Thank you so much for allowing us. Next slide. So basically, we will take the next couple of minutes to take you through A360's approach to tracking and measuring continuation, contraceptive continuation, and our focus population is adolescent girls 15 to 19 years old. We currently program in Kenya, Ethiopia, Ethiopia, and Nigeria. In Nigeria, we implement different interventions in the south and in the north. And our presentation will focus on the north of Nigeria, a bit on the south. And for Ethiopia, we'll be talking about our experience with tracking continuation for married adolescent girls, while in Kenya we'll focus on both married and unmarried adolescent girls. And these three circles basically represent a 360 strategic pillar, and our conversation today is about our first strategic pillar, which is to strengthen the A360's interventions so that they are effective in supporting girls to be able to use contraceptives based on their needs, but also their preferences. And that's where continuation really falls. Next slide. Next slide. So A360 uses a blend of methods to be able to track and measure contraceptive continuation. Next slide. Some of the methods that have already been spoken to, but we will be glad to share our experience. The first packet of approaches is provider-led tracking. I'll be able to speak about that in the oncoming slides. We use the contraceptive calendar method, as Gabriel has highlighted. We are able to use service registers and are able to do retrospective reviews on individual client charts, or what are called family planning cards. And then finally, we also institute longitudinal studies to be able to collect more robust data on contraceptive continuation. So the next oncoming slides will basically provide more nuanced details about each of these approaches. So what do we call provider tracking approaches? Next slide. And I'll be sharing about our experience in Kenya and Nigeria. First, for Kenya, we use the District Health Information System, DHIS2 as we call it. And the DHIS2 has a function where you can be able to capture events. An event is like a session when clients would basically visit to come to the facility for a refill, or to have an engagement with the service providers at the health facility levels. And we use the DHIS2 tracking app that is hosted on Android. So it is an offline application. And so we are able to support providers to be able to capture all the events that adolescent girls who are contraceptive users engage with the health system. And then we complement that with follow-up calls. If the clients do not turn up on the date that they are expected to return, providers engage them with follow-up calls. And once they have been able to engage with the clients, they are able to capture the status of contraceptive use with the client based on the information that is relayed during the visit, but also what is captured during the follow-up calls. And I will be able to share a bit of that. We did this tracking for the 4 counties in Kenya where the 360 interventions are implemented, and I would share a bit of results about that. The second approach that we use providers to track is in our program in northern Nigeria. Providers have an algorithm for following up clients as part of supporting them with contraceptive continuation, and this only applies for short-term method users. Providers call clients twice in the days immediately after they have adopted a contraceptive method, and then a couple of days before the expected date of returning for a refill, so that they can be able to remind them of their appointment to return for the refill. Next slide. And we use an Excel-based tracker to be able to capture the information that is hosted on SharePoint. So our experience for Kenya, so we did this follow-up between 2022 and 2023. It involved 670 adolescent girls from Narok, Kilifi, Homa Bay, and Migori. Large majority of the girls that we followed up were 18 to 19 years old. Majority of them were on implants or the injectable. And of course, we were able to follow them up for a 12-month duration. And as you can see from the chart on the right, the contraceptive continuation rate was 85% at 12 months if we consider the method that they were initiated on at the beginning. But if we factor in that they were still protected because they were using a different method from the one that they was initiated on, then the continuation increases slightly to 88%. So basically, we are able to show within the program that the continuation rates are relatively higher than what is reported in the demographic health surveys by using providers to be able to track on their clients. And the results for switching methods, which is a predominant reason for shifting between methods, is a side effect or a health concern needing a more effective method. And of course, across the 3 countries, commodities are not consistently available, and that is a key primer for switching between methods. Next slide. And for Nigeria, which I described, that providers make a call to be able to offer continuation support, but also be able to invite clients to return back for the remainders. We were able to make a total of slightly over 3,000 calls for the Northern Nigeria program, and just slightly below 5,000 calls for the girls in the Southern program. Next slide. And when we look at the continuation rates, we do see that basically the continuation rates are much higher for the girls who followed up just before their date to remind them the date that they are expected to return for a revisit. So if the girls are called and reminded of their revisit, they end up returning for a visit and continuing to use their method, compared to if a call is done much earlier. I think that is important, because I think being able to remind girls is probably a higher premium than being able to call them to establish whether they have any challenges, although those still provide complementary supportive functions. Next. So the key reflections really on using provider tracking approaches is that providers can actually use this as a form of providing support for contraceptive continuation. Of course, it relies on mobile ownership, and in northern Nigeria, this is one of the challenges that we experience. And then, of course, it provides additional work to providers, and there is that element that providers might exert an indirect pressure to girls to be able to continue with a method, even when that is not their desired choice. And then, of course, there is additional support that is required for airtime and internet, and also, of course, the DHIS2 event capture application is not also very stable. Next slide. The next approach, which Gabrielle did presented and was coming, she did actually presented that more nuancely, but we also wanted to highlight that this is an approach that we used. We embed this approach as part of our population-based surveys. So these surveys we conduct in the communities, and the purpose is to be able to determine whether we are serving girls to address their contraceptive use needs, but also that we are able to capture more information about whether or not our interventions are effective at creating demand and for voluntary adoption of contraceptives, but also supporting contraceptive continuation. Next slide. So we use the contraceptive calendar. I think there's a lot of information on the internet. It is reliably used as part of the demographic health surveys. It's usually based on questions in the survey questionnaire. All the contraceptive use episodes are mapped onto the calendar, and then there is a coding algorithm, and then a live table analysis or more detailed modeling is conducted to be able to estimate the contraceptive continuation or discontinuation rate, as you have seen from Gabrielle's presentation. So we'll be able to share some of the results from Ethiopia, our study in Ethiopia and Nigeria, in the next slide. Overall, for Ethiopia, we can see that the contraceptive continuation at 12 months is around a third of the girls, just slightly around a third of the girls are discontinuing methods at 12 months, and which is almost in keeping with what we have observed from the surveys that Gabrielle has been able to showcase. And we do notice that there are not much differences between girls who were part of continuation from our program and those who are from comparison geographies. Our program is implemented within routine health systems and just shows that the government health systems are still working well to be able to support girls to be able to continue their contraceptive methods. So this is an example, and you can see that those who are using implants have a relatively higher continuation rate compared to those who are using the injectable, which is the most commonly used method in Ethiopia. Next. When we look at discontinuation rates in Nigeria, again, as we have seen, approximately a third of individuals will have discontinued at the 12-month period, and we see that those who are using the injectable have relatively higher discontinuation rates than those who are using the implant. Again, also speaking about why it is important to promote choice, but where opportunities present, girls can be encouraged based on their life circumstances and needs to be able to use the methods that are less laborious, which do not require more intimate engagement with the health system. Next slide. So using the calendar approach as part of surveys, of course, is a good approach. It is what is used for the demographic health surveys. It is has its own slight pitfalls, which include subject to recall bias. I mean, oftentimes because of infrequent sexual activity and, of course, other parameters that have been described by my previous panelists, it does show that remembering all those episodes is very problematic. And so it is very possible that there could be underestimation or estimation depending on how much individuals can be able to recall. Of course, collecting data through surveys is very labor and cost intensive. And of course, it's not possible to be able to fill these surveys within routine health systems. I mean, there are countries that are still struggling to finance their demographic health surveys. And so it is something that we need to think about using this as a tool for monitoring contraceptive continuation, but also that a lot of training is required so that clean data is collected from the field. Next approach. So the second to last approach that we normally use is that one of using the HMIS data. So that is data that is normally collected in the service registers as part of our tool that we can use for tracking contraceptive continuation. And in these oncoming slides, I'll be able to share about how we use the data that is captured through service registers to be able to demonstrate how much girls are continuing or discontinuing with their method of use. Next slide. So one of the things that I also wanted to mention is that in all the countries that we implement, at the end of the month, providers are required to generate an aggregate report that summarizes the activities for all service areas: MNCH, malaria, HIV, TB, nutrition, FP. And one of the challenges is that they do collect a lot of data in the service registers, but not all the data gets into the aggregate reporting form. And so what we do is that we go to the service registers and abstract information about the state of contraceptive use, the status of contraceptive use for the clients that are served. And that enables us to be able to disaggregate to the population that we are interested in. So this abstracting is important because we are able to tell between new users and those who are returning for a refill of their methods. And this is important because we can be able to use this as a metric for forecasting demand, for new demand for contraceptives, which is important for quantification of commodities, to be able to fill in a void for contraceptive commodity insecurity, but also be able to support ministries to make decisions around which demand creation interventions are fruitful or not. Next slide. So this is a summary of what we are able to generate. Of course, as a program, we can be able to generate data, segregating between our clients as whether they are new or whether they are repeat clients. And as you can see, across all the countries, over half of the clients that we serve are returning clients. So in other words, they are returning for a refill of their method, but we also, of course, predominantly serve clients that are coming in for new services. And there are several explanations for this. One is the clients who are returning, mainly those who are returning, who are using short-term methods. So long-term method users are not able to return more frequently to the facilities unless they have a problem, and so will not be routinely captured in their service registers. Next slide. When we look at the trends over time, which is
if you can hear me, so I'm really sorry again. So we are running out of time. Would you please, summarize and, hand over to Pulama, or, we are, less than 30 minutes, to even 25 minutes. Thank you so much.
Okay, I have one or two slides. So this is a trend, of course, A360, because of sustainability of its interventions, has been working collaboratively with government, transitioning stewardship for implementation to government stakeholders over time. And you can see the greens represent facilities or service that is led by government, and the blues represent service that is led by A360. And as you can see, progressively over time, we are registering more clients returning back for refills out of the number that is cumulatively being initiated on methods. Next slide. So in terms of reflection, of course, this data is readily available. It is in the service registers, but there are a couple of challenges in that these service registers are cross-sectional. The participants, the individuals do not have unique identifiers, so you are not able to longitudinally track them. And there is a risk of underestimating continuation because the service registers, there are no universal guidelines about how frequent clients on long-term methods should return to the facilities unless they have a problem. And providers can actually misclassify clients in the course of recording information on the registers. Next slide. So the last approach that we also have is retrospective surveys. Next slide. So what basically means is that we go to the individual client records and we are able to abstract information from those records. It is reliant on whether the national health system has family planning cards or charts. In Ethiopia, we use the Tiko boxes. In Ethiopia, we have FP register. In Nigeria, we have FP cards. In Kenya, we don't have client cards, and so that's why we are not able to report on the use of this approach. Next slide. So for Ethiopia, what we have demonstrated, next slide, is that when we use these chart reviews, we are able to document the continuation rates across time. Of course, we only include data where we have a record for each of the time points, and we can see that the 12-month continuation rate is 69%, and this is almost in keeping with what we are able to document from the surveys. The difference is just like, next slide. And when we look at the comparison between short-term and long-term methods, you can see the 12-month continuation rate is around 50%, while that for long-term methods is almost universally 100%. Next slide. And these are the reasons for switching between methods, which is a common phenomenon. And I think clients do not provide a reason, but the need for be able to access a more effective method is a predominant reason for switching between methods. From here on, I will allow my colleague Kulama to share the experience for retrospective surveys in Nigeria, and also to talk about the last method that we use. Thank you.
Thank you, Dr. Musa, and good afternoon, everybody. I will walk us through the retrospective, looking at the Nigerian context based on the existing record over the period of the A360 implementation. Next slide. During this retrospective process, we're able to record 1,547 clients on the record, basically looking at the client card and NHMIS registers across the facilities. We're able to do this across 100 facilities, and 87% of the clients were married based on the programming for the A360 program, and about 13% were unmarried, basically from the southern part of the country. For context reasons, in the northern part of Nigeria, basically the programming is for the married adolescent girls. And based on this, 38% of this record of this client, adolescent girls, completed secondary school, and 11% completed primary school. We have few clients whose educational status were not able to establish based on the record. Of the 1,500 record extracted in the facility, we're able to see that 724 are users of the long-acting reversible method, of which a majority opted for Jadel, and then we have 43% also in Planon and 11% IUCD. When you look at continuation rate, just like previous presenters, you can see that for the long-acting method, our continuation rate is about 97%. Then we have few episodes of switching, about 1%, and also restarting, and then discontinuation of 1%. Able to record that based on the record. On the other hand, looking at the short-acting method, we're able to see about 873 clients who opted, and the majority, about 72%, opted for injectable, and mostly Noristerat, that is the 2-month method. Continuation rate among the short-acting method is about 74% over the period of 12 months. And then we're able to see some episode of discontinuation of 15%. This is similar to previous presentation from other countries. You can see switching as well. We're able to see some episode of switching and restarting across the users. We're able to see some of the behaviors in the longitudinal tracking. Next slide. Discontinuation rate is highest when you look at educational status, one of the demographic we obtain. We're able to see that discontinuation is highest among clients who completed primary school, and then also able to see that discontinuation to happen high among older adolescents within the age of 18 and 19. Basically, but over 70% of the record trace were within the age. So we're able to see that happening. Very interesting to note the switching among higher people that have highest level of education, that is post-secondary. We're able to see that a lot of them are actually switching. When you look at some of the reasons for discontinuations documented on the record, the client card and also the NHMIS register, and also true calls, just to mention that the retrospective is designed in such a way that some of the clients are traced through provider call to confirm the status of contraceptive, especially for long-acting method. And we're able to see that most common reason is intention to get pregnant. We're able to see that also happening. And then few of the clients cited husband refusal, just 2% as that. So these are some of the enabling environment strategies that the 360 is deploying to see that both the husband and the adolescent girls are enlightened with regard to access to contraceptives. Next slide. So our reflection from the retrospective design is basically client cards are available and accurately completed. There is need to ensure that's happening across over 5,000 facilities in the geographies we implement. Providers receive training and support as part of the vertical integration process. We're able to see that the need to ensure trainings, especially the deployment of the novel counseling for choice and also youth-friendly health services. This helps to ensure that adolescents are treated with the required respect and also influence return for contraceptives. So there is need for training. Safety and confidentiality consideration need to be put in place, and also the link of the client card with the register. This has to be strengthened as well. And also a routine data quality assessment is needed to ensure that the flow of data is optimum across the facilities. Next slide. So next is very important is the longitudinal studies, which was implemented in the northern Nigeria, basically part of North Central and North Western Nigeria, to deploy the longitudinal contraceptive continuation. We're able to trace about 1,100 clients. Next slide. 1,100 clients basically were enrolled during the study. We started this in the fourth quarter of 2022, and this is across 15 facilities in Nasarawa and Kaduna State. Basically, eligibility criteria is based on the girls' age group that we program for as a project. The design is a prospective cohort, and also based on the follow-up, we have 4 waves of follow-up, 3.5 months, 7 months, 10.5 months, and 14 months. This is basically based on the WHO recommendation of giving 17 weeks for injectables for the efficacy of injectables. So looking at that method mix, we're able to see the most adopted method has been injectable, followed by implants and then oral pills. Next slide. Yes. We're able to understand the continuation rates over time post baseline. You can see we have a very good continuation rate of 68% among the short-term methods. This is almost in collaboration with the 72% that we have seen in the previous retrospective design. And also we're able to see of the total sample, we're able to see 22.9% at the end of the fourth follow-up to be continuation among the users of long-acting methods. There are shifts over time, over the period of this research. And the next slide, we'll be able to see some of the dynamics looking at the contraceptive use over time. With regards to the main categories, we're able to see the yellow representing injectable, purple is for the pills, and also the pink is for non-method, and the orange is basically the lack. And this is a Sankey chart, basically indicating flow of some of the methods to see how switching is happening over the period of the 5 time points from baseline to follow-up. We're able to see that most adopted methods to be injectable, followed by implant and then pills. When you look at the flow, we're able to see that consistently the injectable has been the most used method. We're able to see clients from some using the long-acting reversible method after the first follow-up to have switched to the use of implants. And also we're able to see some users of injectable in the third follow-up, that is, third follow-up, we're able to see that switching to other methods. As you can see the flow from injectable, we are able to see some trace of yellows at the no method, which is discontinuation up there. We're able to see that. Very importantly, also, we're able to see client from injectables coming into the long-acting method. So basically, looking at the dynamics, we're able to see the switching. We're able to track switching from individual methods that is being available in the facility. Yeah. So thank you very much.
Thanks so much, Bulama and Dr. Musa, for your insightful presentation. We really appreciate the A360 strategy pillars and the A3 tracking and measurement approach, and well covered and the experience of Nigerian kids. Thank you so much. And now, just to best use of our time, we have a lot of questions coming from the chat box. So I think we are a little bit running out of time. I would suggest to use this time for the Q&A, at least to have 1 or 2 questions per presenter per panelist, so that the questions are well addressed. For those questions not addressed during this time, we will go through it, and the panelists will share with us those responses along the recording of this webinar. So just to start with, we have a lot of questions coming via the chat box. So I will give the chance for the panelists to respond at least 1 question, and then I will see if you have enough further or more time. Thank you. So let's start with the question I think a lot of questions are coming, but let's start with Dr. Hilda's response. At least just select Dr. Hilda, just select 1 question and respond on that, and we'll proceed for the next presenter. Thank you.
Thank you. Thank you. Thank you, everyone, and thank you for the question. I think the question was Tiko's contribution to continuation or uptake, I think that was. So I just posted here an answer, but I wanted to say Tiko's contribution to uptake and continued use of contraception will obviously vary by market and who else is a player in the market or in the subnational levels that where we are implementing. So, but just to say, there are a number of things that we are doing to encourage not just uptake, but continued use. So for example, we use behavioral science techniques. We nudge users. When a user registers with a phone, we send them a reminder to come back for a refill. We incentivize them by giving small reward points so that they can encourage behavior. We also track the quality of counseling that users are receiving using our routine client exit interview surveys. So in those surveys, we are able to track, for example, whether users have been counseled across the method information index plus measurement. So whether they've been told about the method, about side effects of the method they've selected, what to do if they face side effects, and the fact that they have a choice, they can switch to another method. So we track quality of counseling using this data from routine client exit interview surveys and plan trainings for health providers just to improve on the quality of counseling. We also do a lot of demand generation with our users, either through the community agents or even through the providers themselves. So we're able to give users information around, all of this information about the choice they have in terms of the method, so that in case they face side effects, they don't have to stop using, that there are other methods that may be available or may be good for them. So we do quite a few things, and just to mention some of those. So behavioral science, tracking the quality of counseling, and empowering health providers to improve the information that they're providing to these young people, but also doing demand generation to provide information to users around the range of available methods, and that they can switch to other methods. Thank you.
So much, Dr. Linda. The next, I'll give the chance to at least to respond one question for Gabriel, if any, and then Dr. Musau and Bulam as well.
Thank you very much. I think there was just one comment on Côte d'Ivoire for me, if I'm not mistaken, and it was trying to understand, when you have this type of analysis, what's the programmatic response? And I would go back to how I concluded the presentation with women or young women, adolescents sometimes discontinue because they want to become pregnant. So we should expect to see discontinuation, and or they don't require a method that they're on full time. So there's those dynamics to consider. However, I think because of the high rates of concerns with side effects, particularly in some countries more than others, that suggests that overall programming around quality and comprehensive counseling is not happening. And I think we just have to remember, or be humble enough to recognize, that these are large countries, large systems, and our projects are relatively small. And to have an impact that we would see at a population level, we really have to be thinking about scale and how to nudge these systems, to borrow the behavioral science term, towards meeting the needs of adolescents. And a final point is, if we're meeting all women's needs, we should therefore be meeting adolescents' needs. So a quality integrated program that links up with a spectrum of adolescent or SRH services is critical, particularly post-abortion or safe abortion care. Thank you.
So much, Gabriel. Dr. Musau?
Yes, we had one question about side effects. How do we ensure that clients are educated but are also able to manage side effects well? And I did responded on the chat that for A360 we have adopted counseling for choice, which is a PSI's flagship approach for contraceptive counseling, and there is evidence that I did share on the link that takes us to more resources about how providers can use the approach. I would, for the interest of time, persuade our audience to click on that link and be able to engage with the content that is there. But I agree with everybody that yes, side effects need much more dedicated attention by providers when they are serving the clients.
So much, Dr. Musau. Just for a reminder, dear participants, if you were not, able to answer your question either through the chat or during, this webinar, there will be an opportunity for the responses to be sent to you when all the materials are shared after this webinar. So we have not overlooked the question that you have that come in. So just I want to remind it. With that, I think we have got a lot of information, a lot of updates and experience from the presenters, and I would like to thank all the presenters and the panelists for the wonderful and insightful presentation. And thank you all so much for joining us today. We really appreciate your active participation and your engagement during this webinar. And I want to also thank the PSI S360, FP 2030, and Tiko for organizing such a wonderful session. So thank you once again for joining us today. So before we are closing the webinar, I want to highlight this recording will be shared with you all. And thank you. Have a wonderful and enjoy the rest of the day. Thank you all. Bye.